Good afternoon. I welcome you all to the JIPMER Scientific Society External Oration for the year 2019-20. I request Dr. Dasari Papa, President of JIPMER Scientific Society, to conduct the proceedings for today.
Yes, not locked.
Yeah. Hello.
Hello, good afternoon, sir.
Yes. Good
Can
afternoon.
you hear us?
Yes, I can hear you loud and clear.
Okay, sir. Are you ready at your hand?
Yeah, we are ready.
Okay.
You let us know when to start.
Yes, sir, we'll start. She has to put me on ready.
You are there. You're already.
Yeah.
Which are it?
Not stop video.
It's not going, no? Okay. Good afternoon, and I welcome all of you to this external oration. Respected Director, Dean Research, Dean Academic, and esteemed faculty, students, and residents. So this is the last meeting of our team. We plan to hold this external oration on 9th of April, but due to this COVID times, we could not. So we are just completing the process by this June. And I'm very thankful to Dr. Shailesh Puntambekar to have agreed to deliver this oration via Zoom, but we were missing his visit to JIPMER. He was supposed to visit us under surgical gastroenterology, under transplantation program, and also our FOXY. And we made arrangements, but we are very sorry that didn't happen. Coming to the aim of our JSS, just to tell sir that this JIPMER Scientific Society started as clinical society in 1964, and now it is called Scientific Society. The aim is that to have scientific deliberations among our faculty, students, residents regarding the research that is developed in JIPMER. That is the first aim. The second aim is to have collaborations with our alumni and also throughout the world scientists. So this is one of the endeavors that we chose you to give this honorable external oration. And the topic is very much to our heart. The idea is that, so uterine transplantation though happened in India and it has come in a lot of media, many people, even medical people, are not very much aware of it. As much as they are aware of in vitro fertilization, and India is on the forefront in vitro fertilization. As the world's second baby, Kanupriya Agarwal, alias Durga, was delivered on 3rd October 1978, just 3 months later than the world's first baby, Louise Brown, who was delivered in UK. And unfortunately, our efforts of Subhash Mukherjee was not recognized, and I feel Dr. Shailesh Puttambekar has done us so much proud to India. Is I mean, just more than Dr. Subhash Mukherjee, I would say. And uterine transplant is only indicated for childbearing, not for any other purpose, not for menstruation. And now it has, today is supposed to be the world's menstrual day. I don't know, it just happened, but I just want to clarify that uterine transplant is indicated only for childbearing. After that, one or two children are born and it needs to be removed as lifelong immunosuppression is needed. So now I welcome you, sir, for this, and you will be formally introduced by Dr. Biju. I'm unmuting.
Yeah, good afternoon and welcome, sir, for this JSS meeting. Am I audible?
Yes, yes.
Yeah. I think Dr. Shailesh has visited JIPMER in 2015. Hope you might be remembering. He came for our laparoscopy program and he presented a beautiful lecture come video on D2 gastrectomy.
Yes.
So that time he was probably the only person willing to present that. I distinctly remember, and many speakers was not willing because it was a live practical video demonstration of the skill. Dr. Shailesh is currently working as a medical director of Galaxy Care Hospital, Pune. And he's one of the early proponent of robotics in India, robotic surgery. I'm sure it is more than 10 years, and that time very few, I might be recollecting one or two people only proposing robot in India, and he was one of them. And he was the pioneer to introduce a technique called Pune technique of lap radical hysterectomy. And his milestone comes in 2018 October when he did first uterine transplant in India, as well as first total laparoscopic uterine transplant in the globe as well. So he made India proud also. He's basically an alumni of Tata Institute of Mumbai, and he worked in KM Hospital, Army.
What happened? What happened?
It's like Dr. Biju lost his internet.
Shall I finish it? Shall I introduce Dr. Shailesh Prithambecker? He has graduated from Pune University and with a lot of distinctions. And later on, he worked in Tata Memorial Hospital and KM Hospital, Pune. And now he is the owner of Galaxy Laparoscopy Center. He has 9 book chapter publications, and he has 18 awards, all national and international. The list is very long, and he has also conducted a lot of live workshops. The list goes on, more than 123 live workshop in India as well as abroad, almost all countries, Pakistan, Australia, to name, I think all countries in the world he visited, and he has been training many people, young people in laparoscopy as well as robotic surgery. So I won't take much time, sir, and your CV has been circulated among our faculty and residents. I request you to deliver the lecture. Just I will share one slide of mine. If you can unmute. No, I can share. So we are actually, I have to, where is my slide? We have to give you officially an Where, how to go? Yeah, my slides. Open it. Okay, sir. At the end, we will send you the medal. Just open. So this is the certificate which will be sent to you later. Then one more slide is there. Not open. Huh? Just go here. Minimize that. Minimize. Just, minimize. There is one PowerPoint there. Just get that PowerPoint. Just minimize this. Yeah. Welcome you, sir. So I just made this slide because we are not there in person to give you put you the medal. So please go ahead and deliver your talk. Yeah. Just one. Yes, I mean. Sir, please go ahead with your presentation. You please share your slides, sir. Close one. Ask. Yeah.
Good afternoon. Are you able to see the slide?
Yes, sir. Yes, sir.
So good afternoon. Thank you very much, the JIPMER societies. It's a pleasure and honor to deliver this oration. It would have been a great experience if I would have visited. Me and my wife wanted so much to come to JIPMER and visit the French quarters also. But unfortunately, this was not to take place, and such a coincidence that I'm delivering the lecture on the World Menstrual Day. So in the next few minutes, I will take you through this fascinating journey of uterine transplant, which we did in 2017. And when we had the, so hello everybody, this is your institute that we had, and greetings from Galaxy Care Hospital, which is in Pune, which is about 140 kilometers south of Bombay. So, okay. So at the stroke of midnight on 18th of October 2018, India was liberated again, as you could see, and we made our country extremely proud because this was the first baby who was born out of the uterine transplant, which took place in May 2017. And this was the first live pregnancy that we had after the first two transplants that we did. So on October 18th, we made this dream. This is what we dreamt about, that we would be able to give a very good live baby after the transplant. This dream we had in 2014, and it took us almost 4 years to realize that this dream became a reality and almost made it completely possible. So our success was constantly covered by everybody, and everybody thought that it is something which was just a kind of a thing which happened. But of course, it was not. It was a sheer effort, team effort, and a sheer effort on the technical, anatomical, and understanding the physiology of the uterine transplant. And thus we created a stir in a scientific research area. So the journey so far was quite interesting. When we did the first transplant on May 18th, 2017, the headlines, of course, said that we had done the first transplant, but not everybody was nice. And we had certain headlines saying that, is it really necessary? But then again on October 18, 2018, we had this mother's womb delivers a girl. And you mentioned, madam, that the first girl out of the IVF pregnancy in 1978 in Cambridge. And the headline at that point of time was, it's a girl. So the first baby who was born out of IVF in the world was also a girl. And after almost 50 years, the same headline was there, that it's a girl which was delivered out of the uterine transplant. So this is what were the various headline, and you can see that wait ends for India's first uterine transplant baby. It's a girl, and this was the same headline which was there in 1978. The whole story of transplant is that if you really dream of something which you really want to aspire and do something in your life, it seems that if you are really truthful to what you want to do, the whole universe will help you in achieving this. And we had this experience. So the first transplant of the world took place in 1931, and this was in a transgender woman on a Danish girl. And this is an Oscar-winning movie which was made in 2016. So you guys can watch this. This is the Danish girl which was made on the first transplant, but the lady died. The transgender died because of the rejection within 3 months. And then, of course, there were a lot of experiments which were happening in 1896, and also certain experiments were done on the dogs. But the first stir was created when a baby was born out of a transplanted uterus in 2014 in Gothenburg in Sweden. And this was due to a huge effort by Mats Brainstorm, who came from that area, following which the other babies were born. And when we delivered our baby, our baby was the 12th in the world. 9 babies had been born in Sweden and 3 in United States. And the 12th baby was our baby, which was named as Radha. So this is the way in which the history was made. This is where we did the cesarean section at around 2:30 in the morning. We were very sure that we will have to do cesarean hysterectomy because we don't video. You can see the baby in about less than 2 minutes was delivered, and this was a girl. And once we applied the clamp to the umbilical cord and the baby cried, everybody inside the operation. So this was like the biggest moment for us. Everybody who was in the operation theater had tears in their eyes because this was a baby who was born out of the transplanted uterus. And these are the first pictures. So the first baby who was born out of a transplanted uterus in the world was named as baby Vincent. And when we got our child, we named it as Radha because this lady came from Baroda, from Gujarat, and we thought it is appropriate that we name Radha. So the question is, what exactly is uterine transplant? When is it done? How is it necessary? So a uterine transplant is done for what is called as a uterine factor infertility, or AUFI, and the causes are congenital. The commonest cause is the MRKH, non-functional uterine anomalies, and of course in the acquired ones, when you have the uterus taken out, or either because of the cancer or for emergencies, or when there is a rupture or atony. In India, out of 5,000 females are born with MRKH, the Rokitansky syndrome, where everything is normal, the ovaries are normal, sometimes they have just one kidney. So we expect around 12 lakh patients at the end when we see this. Since we did the first uterine transplant, the number of cases who are waiting for transplant are about 476, 228 are married, and unmarried are 248. The question was, when we did a transplant, why don't you advise the people who are born without the uterus or those who do not have the uterus, why don't you tell them to undergo adoption? Well, adoption has its own psychological issues, and we know that adoption is easier said than done in our society. Surrogacy is always an option, but again, it is an ethical and philosophical issue. Not many countries in the world allow surrogacy, and therefore India was the surrogacy capital of the world. And there are very absence of legal provisions, and it is commercial surrogacy, so that even the parliament has taken. So we had these stories boom for rent, and the sad stories which came out of surrogate mothers. We all know about this, and of course the single parents who want their babies through the surrogate mother, putting the woman under the having surrogacy under the risk. So the surrogacy bill was not adopted because the commercial surrogacy bill, I should not be going into the details, but this was taken cognizance of in the parliament also. Now the question is, what does uterine transplant do? The uterine transplant is an answer to complete motherhood. So adoption will give you legal motherhood, surrogacy will give you genetic motherhood, but if you do uterine transplant, you get legal, you are genetic, and also a gestational motherhood and whole experience of becoming pregnant. Every woman who is out of about 23, 24 years of age always aspires to be mother at some point of time. And when somebody is denied of the motherhood, that's the people whom you should be asking about what is required. So the spark came when I was visiting United States, and we heard the lecture of Mads Brainstorm, who had done the first uterine transplant. And when I was going through the lecture, which was a brilliant lecture, and everybody gave standing ovation, but few people like me had certain points in our mind. Why are they taking 14 hours to retrieve a uterus from the donor? Why? I mean, a uterus, an organ, you cannot take 14 hours to take out the uterus. Why ovarian vessels were not used as the outflow channel? And of course, why this cannot be done laparoscopically? And of course, being an Indian, why is it that we cannot do it in India? So the tools change, the wisdom remains. We decided that we will do a transplant, but we will do it transplant laparoscopically. Now remember, this was in 2014. So with this 2014, our plan was that we will probably have a lady who is born without the uterus. We will do an ovum pickup, then select the mother or sister who has a good uterus and who's premenopausal, do the transplant surgery laparoscopically, use immunosuppression, and after that we do an embryo transfer and get a pregnancy, and in follow-up we'll remove the uterus. So this was the plan of action, where to select a girl who is born without the uterus, have a mother whose uterus is intact, first extract the embryos, so you do extraction of the oocytes and do embryos, then do the transplant. After the transplant, 6 to 7 months later, then transfer the embryo, and after that you deliver the baby through cesarean section, and once the baby is about 7 or 8 months old, you can take out the uterus, because uterus is not there for menstruation. And with this, we started our preparation for uterine transplant. So all the people who did the uterine transplant in the world did animal experiments. That is, they tried to put the dog or the sheep's uterus and then transplant. We thought none of this anatomy matches that of a human being, and therefore when we do this first time in a human being, it's going to be very, very difficult because the anatomy is different. So we decided to do our training on human cadavers. Now human cadavers are not easily available to us in India, so I had to travel to Sweden, I had to travel to Germany, and I had to travel to Turkey, and then sit with the cadaver. So this is a cadaver, and learn the anatomy right from the origin of the internal iliac artery, as you can very clearly see here, and the internal iliac vein, which you can again see, and how we are going to harvest this laparoscopically. So this is how we learned, and we prepared ourselves. We did this, the dissection in almost about 7 to 8 cadavers, working alone and trying to understand the anatomy. And we could see that our anatomy, though I was doing a lot of cancer cervix work, this is different. You have to harvest the vessels right from the origin of the internal iliac artery and the internal iliac vein. And this is the kind of training that we underdid. So you can see this is a training that we did on the human cadavers. The next thing that we did was, every specimen of cancer cervix that we took out, we were using methylene blue dye through the uterine artery and trying to find out if we use one uterine artery or the internal iliac artery, because we don't take out internal iliac arteries in a radical hysterectomy specimen. So we were in radical hysterectomy, we cannulated and tried to find out whether we can do a complete removal of the uterine artery and the uterine vein. And we realized that when we try to put and inject the methylene blue dye just through one uterine artery, the entire uterus was becoming blue. This showed that the uterus is complete with just one vessel. It can supply the entire uterus, and therefore one vessel may be sufficient. So this was what we did. This is called as a bench surgery. The next question was to get a permission from the government. Fortunately, health is a state issue. And when we went to our politicians and we presented the entire data to our politicians, they realized that it is worthwhile giving. So we were the first state in the entire country to get this, to get the permission for uterine transplant, and we got this for 5 years. So we had the ethical clearance, no bureaucratic hurdles, and even before the other states could give permission, fortunately, our politicians gave us the permission. The next thing was to form a team, and this is the way in which we had to form the team. The team was like, if you have seen the movie called Lagan, when Amir Khan tries to form the team, nobody in the team knew how to do a transplant. So we had to involve all the doctors, but none of them had the ideas. So we had to train ourselves. And then we had to decide the plan of action, how we will take out the internal iliac artery of the donor and anastomose to the external iliac artery and the internal iliac vein and the ovarian vein. So this is what we decided to do. So this is the team we formed, and we had IVF specialists, plastic surgeon, vascular surgeon, gynecologist, high-risk obstetrician. So a team of 16 people was formed, and for almost 2 years, every day we used to meet at 8 o'clock in the morning, all private practitioners, to decide how we are going to do the transplant. And this was for 2 years. We thought about every step, everything that can go wrong, everything that can go right, and this is how we formed this. So are there any criteria for doing a transplant? Of course, there are criteria, what we call it as the Montreal criteria. The Montreal criteria defines who should be the recipient, who should be the donor, and who should be the healthcare team. So recipient should be a female by XX. It cannot be XY. So a genetic female should be married or should be in relations with somebody for more than 2 years. Most important thing is you can't do a transplant from an unmarried a person or a person who's not in relationship. And of course, she should be less than 35 years of age and should exhibit the idea, or psychologically she should be ready for motherhood. The donor should be a female of reproductive age or up to the age of 55 with no medical contraindications, should have at least had 2 children or at least one, so that there should be a history of parity, and therefore, and of course, no history of uterine damage, and is quite psychologically sane to give the consent. And of course, there should be a complete healthcare team. You all know the American Fertility Society and classification of Mullerian anomalies, so I will not go into this. But the commonest symptom with which the patient presents is, of course, the primary amenorrhea. 90% of the times there is a complete or partial absence of the cervix as well as the vagina, and therefore a vaginoplasty is a must. So this is a laparoscopic view you can see of an MRKH, completely blind vaginal pouch, and this is how the MRKH looks from inside when we do a laparoscopy. So this is a rudimentary uterine horn. You can see both the ovaries, the tubes are intact, everything looks good except the uterus. So the first step, of course, is the vaginoplasty. We had in our team people who could do vaginoplasty, and we did this peritoneal vaginoplasty. So you all know this. I'm not going to take you through this, but this is the vaginoplasty using the peritoneum, and we use the peritoneum to create the neovagina. Now, unfortunately, this is what we did initially, but later on we realized that it is best vaginoplasty should be done at the time of transplant if the lady is already married. Unfortunately, without vaginoplasty, the patients can't get married. Therefore, we are still doing vaginoplasties when the patient gets married, because at least the sexual life goes on. So this is the vaginoplasty that we did. This is how we can do it, using the peritoneum over the rectum as well as from the lateral side, and creating a peritoneal pouch. So this is the vaginoplasty we did. Then We were the first in the world to do transplant surgery laparoscopically. So the donor was, the uterus of the donor was taken out laparoscopically, and this was the one of the most difficult tasks, because when you do a hysterectomy, you take care of the vessels first, and therefore the vessels and the uterus does not bleed. Here you cannot use a manipulator because that's the organ which is going to be used for the transplant. You cannot take the vessels, and the vessels have to be taken last. So this is the dissection that we had to do, and you cannot use a hypotensive anesthesia because otherwise the vessels will go into spasm. So this you can see we did the dissection, and with this you can see this is the uterine artery that we are dissecting. This is the uterine artery, and there are multiple branches of the uterine artery that we realized when we started doing the transplant. Now these branches have to be clipped independently and individually, because when we rejoin the uterus to the recipient, otherwise there will be a leak of the blood directly from the external iliac arteries of the recipient, and therefore each and every vessel was clipped. You can see these are the branches of the uterine artery. The uterine artery is being dissected, and lower down that's the ureter, and this is a painstaking kind of dissection. So you have to dissect the uterine artery till it goes, you can see, into the uterus. So that's the uterine artery as it goes into the uterus there. That's the ureter which is being separated out, and this dissection is done that you should not even let any kind of your dissection damage the intima. So this is the entire dissected uterine artery on the left side. And then what we did was to take out all the supports of the uterus. So these are all the supports of the uterus, because you have to separate the uterus from all around. These are the uterosacral and the McEnroth's ligament being cut. You can lower down see the rectum. So all the supports of the uterus have to be cut till you reach the levator ani muscle. And then we dissected the uterine vein. So this is the first of the time that we use the uterine vein. Later on, we stopped using the uterine vein. So you can see the paravesical space. You can see the anterior division of the internal iliac artery. This is the anterior division. All the branches of the anterior division except the uterine are ligated and they are clipped. So you can see that the vessels are still intact and the uterus is being separated. There is the blood supply is being maintained, and then once you do that, you separate the artery further and completely separate it out. So all this was being done. Then you do a few sutures. This is the vagina. There is the cervicovesical fascia. There are veins underneath that, and you have to take certain figure of 8 sutures so that there is no damage to the veins. And once you do that, you do a colpotomy. You can see this is the colpotomy being done. The vessels are still intact. You will see that. So we have separated the entire uterus and the supports of the uterus, but we have kept the vessels intact. Once we do a colpotomy, we take the sutures of the cervicovesical fascia and denon-villus fascia with a barb suture. This is again to prevent bleeding once the revascularization takes place. So you can now see the uterus is separated. The internal iliac artery is further dissected. The only lateral branch of the internal iliac artery is ligated. Then the internal iliac artery distal to the origin of uterine artery is ligated. So you can see this is the uterine vein also ligated. We still have the internal iliac artery intact. The blood supply is still intact. And once this is done, then you start applying the clamps on the ovarian vein. On the left side, we have already cut the internal. This is the internal iliac artery. Apply the clamp. This is taken out. Similarly, on the right side, the ovarian pedicle. And then finally, the internal iliac artery pedicle. You can see that we have cut it. And then the entire, and this is again the uterine vein, and the entire specimen is separated out. A small incision is taken and the uterus along with its vessel is then delivered. We don't deliver it through the vagina, otherwise the vessels can land up into intimal damage. Then you bring the uterus on a block of ice. This is the block of ice where the uterus is brought there, and there you see the vessels are dissected out. This is the internal iliac artery actually. And then you put the custodial solution. This is the same solution that you use for the kidney transplant. So with this, we inject the dye and try to find out not only the leak, but also to cool down the uterus to minus 18 degrees. And this is done by the plastic surgeons. So the microvascular and plastic surgeons will do this. They completely make the uterus white. For this takes about 45 minutes. Then you inject a cool down custodial solution and cool the uterus further. A lot of ice is put over there, cannulating the flow. You try to find out if there is any leak from the vessel, and then once this graft preparation is done, then you can see that there is a good anastomosis between the uterine artery. So in the last transplants, we have used just the internal iliac artery and the ovarian vein, and we could see that there is a good anastomosis which takes place between the internal. So this is a utero-ovarian anastomosis. We have stopped using the internal iliac vein. And you can see we have had significant length of the pedicle, because this pedicle has to go and reach the external iliac artery and the vein. So this is how we do it. In the meantime, the recipient is being prepared. That too is being prepared laparoscopically, the same way that you do for vaginoplasty. So you are preparing the bed in which the uterus is going to come and lie. This is done laparoscopically. You can see this is the previous vaginoplasty. We open the vaginoplasty and we open the vagina. That's where this is going to get accommodated. And the uterosacral, so-called uterosacral, we are also going to take a stitch. We try to take few sutures, parachuting sutures on the vagina, you can see, and we then plicate the peritoneum. All this is in preparation so that when the uterus comes there, we can support the uterus, because there are no true supports which are available in this patient. So we are recreating a uterosacral using the #1 proline, which is taken from the sacral promontory right up to the area where it is going to be prepared. We also prepare the vessels. After that, we open the patient and we prepare the external iliac artery and the vessels, and few sutures are taken on the wall so that the uterus can be parachuted inside. So all this preparation goes on simultaneously. You can see the vagina being prepared, and then this is all the vessels being brought there, and then this is the uterus which is now being transplanted to achieve the vascular anastomosis. So this is the recipient surgery. In the vascular bed, you can see that the anastomosis takes place first between the ovarian vein and the external iliac. This is the external iliac vein of the recipient. So you are doing the anastomosis first of the vein. This is the venous anastomosis that you do. Once you complete the anastomosis of the ovarian vein, then you can take the internal iliac artery and then anastomose it to the external iliac artery. So this is how you can anastomose to the external iliac artery. This is where we are going to do the anastomosis. This is a fairly simple job. This is done by the vascular surgeon with a 7/0 proline in a continuous fashion. So this is joined, and you can see this is a completed anastomosis of the external iliac artery with the external iliac artery and the vein. We have just joined one vein and one artery, and you can look at the color of the uterus. The color of the uterus is now quite pink and good. Then you fix the uterus to the vagina. So we are now fixing the uterus to the vagina before you proceed for the next anastomosis. So this is how we are fixing the uterus to the vagina, and once this is fixed to the vagina, then you can see the entire uterus nice and clear and healthy, and you can see the color of the uterus over here, which is quite good after the transplant. So it was white when it was on the bench. Now it is completely nice and pink once the anastomosis is complete. So the total time that we took for the first case was about 10 hours. While the duration in the Swedish guy were 14 hours just for removal of the uterus. Donor time was 4 hours, recipient was 4 hours, and of course the outcome was successful. Our first lady had the menses 48 days after the transplant. The length of the pedicle that we achieved was about 11 centimeters for the ovarian and about 9 centimeters for the internal iliac artery. The most important thing is that the pedicle is very, very important because they have to reach the external iliac artery. And if you don't have long pedicles, then they can have tension when there is pregnancy. So this you can see the difference between the open surgery on this side and laparoscopic pedicles on the other side. So this is the utero-ovarian anastomosis that I was talking about. We have stopped using the uterine vein. We use the ovarian vein as the outflow channel and the internal iliac artery as the inflow channel. And then we use this technique. We published this in the JMIC. This was a publication which was published in less than a week. It was accepted, novel anastomotic technique for uterine transplant. So we are the first in the world to do it laparoscopically. We were the first in the world to use only the ovarian vein and not the uterine vein. So this is what we had demonstrated again through the bench surgery. One artery, we inject the methylene blue. It was all the data that was collected by us, and this was a fairly simple thing to understand that with one uterine artery, the entire uterus could become blue and the flow came through the ovarian vein. The lesson that we learned, the uterus can survive with just one uterine artery and ovarian vein. And why am I telling you all this? This makes this procedure duplicable because none of the gynecologists or even gyne-oncologists work on the internal iliac vein. To retrieve the internal iliac vein is one of the most difficult things in the world. If you can do an ovarian vein, it is much, much simpler. So there is no traction on the pedicles when you use internal iliac artery and the ovarian vein because ovarian veins are bigger than the ovarian artery and the length is very, very long. Second important thing that we realize is that the cervicovesical fascia which covers this, there are veins under the cervicovesical fascia. So when the revascularization takes place, this is what starts bleeding. So we started taking sutures underlying because this is to prevent, and we started taking sutures. Again, this is published in our publication, preventing the vaginal edges from bleeding profusely once the uterus is transplanted. So our innovations were understanding the uterine artery. We realized that the uterine artery has multiples of branches, and then once the entire surgical procedure was over, what was important to look after the uterus? Because ladies and gentlemen, this is the only organ which remains outside the abdominal cavity with the cervix projecting in the vagina, and therefore it is because of the fungal infections that a lot of people had uterine rejection. But we had to be very clear, and therefore we had to use ABC. Now with the coronavirus, we are very, very clear about this, but this was being done for the transplant. So we had specialized transplant ICUs with the HEPA filters, and of course you have to give immunosuppressive protocol like tacrolimus and methylprednisolone and myclophenolate, that is MMS, which has to be given. The next question was, once we do the transplant, how do we monitor? If the kidney doesn't function, the urine will not flow. Heart doesn't function, the heart will stop. But what about the uterus? And that's when we realized that we have to do the test to find out that the uterus is functioning well. So we did non-invasive test, which was with the color Doppler, and invasive test by taking the biopsy. So why invasive test? When we did the biopsy, where we did the C4D, which is an immunomarker, to find out if there is a rejection. We did this on the 7th, 14th, and 21st day, and we found out that there was no rejection. We also did biopsies of the graft after 2 months, and then once this was done, then we had the first lady had the menses 48 days after the first transplant, and then it kept on happening every 3 weeks. So the ovaries were of the recipient, the donor's uterus was there, and there was a symbiotic effort which took place between the two, leading to a good menstrual cycle without any drugs. Prior to the embryo transfer, we decided we'll do a color Doppler, and we found out that the anastomosis is perfect. And then this is our evolution. We have done so now about 8 transplants, and we have done the last transplant only with the use of ovarian vein and the internal iliac arteries. The follow-up should be always for removal of the uterus and that should be done after that. So this is the team. Though I was one of the person who imagined it, but it is not without the team that we would have done this. So this was the photograph taken at 11:30 in the night when we did the first ever transplant in May 2017. And we also published this laparoscopic assisted uterine retrieval. This happens to be the first laparoscopic live donor removal of the uterus, and we did the first two, and we also published it. So whatever we did, we had the scientific basis, and we also have a publication. And of course, there is also video, because before we did the transplant, there was no video on how to do a transplant. And we published this video so that everybody could do this. And of course, as I told you, we also have this utero ovarian venous anastomosis. So instead of using the internal iliac veins, do use the ovarian veins. What is the status? All in the entire Asia. So we can see India, we did it laparoscopically. That's a red line. Chinese people also tried to do it with much less success, but they did the first robotic transplant after we did laparoscopic one, and they had the childbirth just about 6 months back. So India did the first transplant, and this was successful in the first attempt. So you can see when we did the first transplant, the guy who did the first transplant and had a live baby from Sweden gave an interview to Hindustan Times saying that India's first womb transplant is dangerous because it is done by surgeons who are cowboys, and which was quite bad, because this, and the same paper 1.5 years later had to say that 600 patients are on waiting list. So when we had this criticism, we did not return back that criticism by giving any interviews. We continued to work, and I personally feel that the work will speak more than the words, which are temporary, and nobody remembers this now. In spite of this, the British people who never believed the Indians had this be an international journal on obstetric and gynecology, which says both the patients of India who have undergone transplant have died, which was a complete fake news, and we sued this journal. But this is something, when you're born in India, it takes a while if to accept it unless you publish it. And then, of course, the same UK gave me Alex Turnbull. Alex Turnbull is one of the biggest gynecologists they have ever produced, devising a lot of operations. So this Turnbull oration, the 27th oration, was given by me last year. And this was a rebut to what the British people thought. And the biggest thing was, after the oration, we had standing ovation, because then Dr. Lisa Johnston, who was a part of the Baylor University and a part of Matt's brainstorm, she was one of the first persons to call me to give oration in Dallas, which was the first uterine transplant international meeting where I went there. And finally, the American Association of Gynec Laparoscopists, which is the largest gynec laparoscopy association in the world with more than 5,000 members, in their annual global congress after the delivery of the first child, which took place on 18th October, the congress was on the 7th of November. They changed the scientific program, and we had to give the lecture.
But we jumped straight to the future. And this is the last step of our evolution, but for the moment, because evolution is temporary, because always changes. In 2017, my very good friend Shailesh Puthenbecker translated this creative surgery under the eye of laparoscopic approach. And so the first uterine transplant with the laparoscopic approach, the minimally invasive procedure proposed by Harry Rich in the 80s, was performed. This is the further evolution. The 18th of October, so a few days ago, the first baby was born from a laparoscopic transplant. Her name is Radha. Look at her face.
So it was indeed a proud.
देखो, पहली बार किसी गोरे को इंडिया का तिरंगा लहराते हुए देख रहा हूं.
So we nailed it with sheer hard work. Diligence was the key to the success. We worked hard, we toiled hard, the team believed in the leader when we had no idea whether we will get success. But it is about believing in the team and the team believing in you. And then this is not something which happens overnight. You do the transplant, you have to wait for 17 months to get the first baby. So during this time, to keep the morale of the team is very, very difficult. And we finally, together in our team and our country, we did the surgical strike where we did it laparoscopically for the first time in the world. We did the first utero-ovarian anastomosis and we were successful. The future is, of course, a robot assisted. We have now got another robot which is called as the CMR robot. And of course, this will be the future when we want to do this. So there is a lot of future. You can almost, the idea is, why don't you do it from the donor after a cadaveric? Because after a cadaveric donor transplant, majority of the results have failed except two, one in Brazil. And this was the first time in Brazil that a donor deceased uterus was used and led to the first pregnancy. The future of uterine transplant, can it be done in transgender? This is a big question. We do not know. Can it be done in males? We do not know. A lot of doors have opened up with this. But of course, there is one of the things which I've learned with the transplant is that when a patient with a pelvic cancer undergoes any kind of radiation, you can bring the uterus to the abdomen and the patient can menstruate through the abdominal cavity. Now, this is done by Retan, who's from Brazil. This is the first one. And of course, a bioengineered uterus can be produced, and which was produced by a Chinese guy. But of course, you don't know how much to believe in that. But artificial wombs are also coming, which is where you will not require any female for surrogacy. You can do this. A lot of work is being done in the work of infertility. This is a scary situation that you can produce a baby completely in the lab. So this is the guy, Benjamin Curson, who was the first guy who separated the Siamese twins. He was a neurosurgeon and he separated the Siamese teams successfully for the first time in the world. And he goes to say that a good surgeon doesn't concentrate on technical ability, which is what is the most important thing, but also to understand when you should be doing and what is the appropriateness of what you are doing. So this is the transplant. This is what we did. So thank you, ladies and gentlemen. This was the first uterine transplant of our country with the success. So thank you again, the JIPMER Society, for inviting me for this wonderful oration. Thank you very much.
Yes. Thank you, sir, very much for accepting and sharing your knowledge, not only knowledge, your views on how to withstand the criticism and then add to progress to the peak of Mount Everest, I would say. I wish we had seen you in person, but because the COVID has collapsed everything, in times to come, when all this is over, definitely we will be inviting you to JIPMER under transplantation program. Dr. Biju is in charge of the transplantation program. We, from the Department of Obs-Gynae, we have already put up the proposal a year ago, and we are at the foot of the Everest mountain. We just started doing ART because after uterine transplantation, you have to make the woman conceive once the uterine functions, and this is done by ART. So we have that basic facility of doing IVF in JIPMER. We just started. So, and we also have a twin OT, state-of-the-art OT, operation theater in Department of Obs-Gynae, where I wish you could come and demonstrate your technique.
Sure.
And this is, yes, definitely, it will happen. I may retire, but I am sure under transplantation program, you will be the first person to be invited. Now, many of the people have seen your skills and also your determination. Once again, congrats, and thank you very much to have spared your valuable time.
Thank you. Thank you very much. Okay. So thank you, madam. Thank you, all of you, and hope to see you soon. And take care. Okay. Bye.
Dr. Subhadra, please say a word of thanks.
Thank you, sir. It was an eye-opener to us. It was a very interesting talk, and you had presented it also very beautifully. We were engaged throughout the presentation. I expressed our heartfelt gratitude to you. I also thank all the participants who have watched the video here. I thank the technical team who made it possible for us.
And also thanks for your technical team. Yesterday also they beautifully coordinated with us. We look forward to meet you in person, sir. Thanks a lot.
Thank
And
you.
I also thank all the participants, JIPMER faculty, students, and residents who have joined and watched this. I'm sure that many of the residents, especially, would have become your fans, because I have listened to you in 2011 in Trivandrum, a talk on laparoscopic radical hysterectomy. That time you were also joking that somebody asked you to deliver the baby via laparoscopic technique, which also some of the people, some of the patients put the same question to us. Here in JIPMER, Department of Obs-Gynae, we also want to develop our gynec oncology, because we have lot of load of gynecological cancers, and we are one of the regional cancer centers in South India, where we give free care to all the cancer patients. That is our strength. And here we do have some of the women who have lost their uterus because of the PPH, and also some cases of MRKH who come from very poor socioeconomic status. And we are running our free renal transplant program, liver transplant program successfully. And our dream is to do a uterine transplant also. I hope you will help us and make the dream come true.
Thank you. Okay. I hope your dream comes true. Thank you very much. Thank you so much. Okay, bye. Bye.
We will be sending you the medal and the certificate because the shops are closed. We could not make the medal in the jewelry shop. So we will be sending it by courier in 2-3 months time. It's gone, no?
Yes.
Thanks, yeah.
Okay.
The support. Yeah. Subhadra, please tell regarding the prizes and further elections and all.
Yes, the prizes, there will be 2 prizes in 3 categories. We will send the prize winners' names. We've not yet finalized. It will be finalized and an email will be sent to the prize winners. And we have planned to hold the election after May 31st. May 31st is the last date for nominations. So please send in your nominations. There are still the vital post, secretary post, president post, for which we have not received any nominations. There are EC member posts also for which we have not received sufficient nominations. So please join to form the next team that will be taking over the presentations of JIPMER Scientific Society. Send in your nominations, please, before May 31st. Anything else, ma'am?
We will get the date from director and make the certificates and mementos for the prize winners. So because the director is very busy today also, he told us his inconvenience of not participating. We will mail when the certificates and mementos prizes will be given by the director. I think within 1 week we will get the date. And then of course elections, you have already sent the details, and then we will be handing over. Anyway, the next year session usually starts from July. I hope we have not made any inconvenience for the incoming team of JSS for the year 2021 and 20. I hope it is clear. Anybody has any questions can unmute them and ask. Anybody needs any clarification, the participants? They can unmute. No?
There were no questions in the chat box, and nobody has raised their hand also. So, can we assume that?
Okay. Okay. Just see. Okay, fine. I think you can end the meet.
Okay, so that brings us to the conclusion of our online JIPMER Scientific Society external oration. I thank everybody, and we'll conclude it for today.